यूट्यूब लाइव भी चालू है मेरा।
हाँ ठीक है।
हाय सुरेश सर। हेलो सुरेश सर। अमीर मेरी आवाज आ रही है तुमको?
हाँ सर, थोड़ा कट के आ रही है।
ठीक ठीक।
Hello. Good evening, sir.
Hi, Milind.
Bye, sir.
Hello.
Sir, topic for the next webinar, shall we take it neurocritical care?
Your sound is not coming. You are still mute or what? Hi, Suhas.
Good evening, sir.
Somehow
Good
I can't
Hi, sir.
hear anything.
Hi, sir.
Hi, Nitin.
Hi everyone. Hi Suresh.
Hi.
How are you? Hi Suhas.
Hi, good evening, sir. Good evening.
Who else is yours? Himanshu? Can you hear me, Suhas?
Yes, sir.
Milind?
Yes, sir. Yes, sir. Clear, sir.
Good evening, sir.
Hi, Sonal.
Yeah, hi. Now I
Hi.
got the sound. Yeah, absolutely. So, good evening, everybody. How's Milind? Yeah, Milind.
Sir, hi.
Everything is okay?
Can you hear me?
Yes, I can. Yes. In
So
between.
the topic for the next webinar, shall we take it as a neurocritical care?
Yeah, I think that would be better, isn't it?
Okay, sir.
Yeah, because
Okay.
rest of the things will follow as a a routine. This let us do something
Okay.
different for the next month's webinar.
Right.
Hi Suresh.
Oh, hi, Uday. Hi. Can't see you.
You can't see me.
Yeah, just
Right.
put your video on. Yeah,
Am I flickering?
flickering.
Yeah.
Yes, yeah, as usual.
That's a Saturday night fever.
Absolutely right. I agree with you. So all the speakers
I
have
don't know why
come
the
on.
bloody video is not.
I can
Catching
see
up.
Sonal. Hi, Sonal.
Good evening, sir. Good evening, everybody.
Very good evening.
Evening.
Where are the other speakers?
You can hear me well, no issues. No?
Yes, absolutely.
Okay.
No problem.
Good evening, Andar, sir. Good evening.
Yeah, hi. Good evening.
How much time is left, Milind, to start? 2 minutes, I
minutes.
think. Yeah, 2 minutes. Okay. Anybody wants to check the presentation? Sonal?
Yes, sir. I will just share the screen.
Yeah.
You cannot start screen share while the other participant is sharing.
Absolutely.
I think Milind, sir, if you
Mm,
can stop sharing for a minute, please.
this program, yeah.
Is that visible to everybody?
Perfect. If you have
Okay.
any video, just check the video. Otherwise, I think
No, sir. I've kept it simple. Yes, sir.
perfect.
I will
Perfect.
stop share.
Looks good. Yeah.
Thank you.
Okay. You are the first speaker, right, Sonal?
Yes, sir.
Sir, it's 8 o'clock. Shall we start, sir?
Yeah. Ask Himanshu to connect.
Himanshu?
Hello.
Oh, hi.
Hello.
Hi.
Sure.
Sorry,
Hi.
can someone tell me how do I join in using computer? So is there a meeting ID or something like that? And I can, because I'm logged in on the phone, but I don't have a ID.
I'll forward it to you.
Okay.
We can go ahead, Milind.
Yes, sir. I will start it, sir. So, good evening and welcome all the members of MCNS to the MCNS webinar series of this month. So today's theme is of pediatric neurosurgery, and we have the eminent speakers, Dr. Sonal Jain, Dr. Saurav Samantray, Dr. Naresh Biani, all are from Mumbai. And our moderators are Dr. Suresh Sankla and Dr. Kishore Chaudhary from Sheffield, UK, and Dr. Sankla from Mumbai. And we have got the eminent panelists, Dr. Suhas Uday Kumaran from Amrita Institute, Kochi, and Dr. Uday Andar from Wadia Children's Hospital, Mumbai. The program is initially Dr. Sonal Jain, How I Do It with Vipishan, followed by How I Do It Myelomilling Ocil Repair by Dr. Saurav Samantray, and after that How I Do It Lumbar Lipoma, Dr. Naresh Biani. And after that we'll have some discussion. Initially, before starting the webinar, I would like to request all the members to kindly register for the MCNS Mumbai 2023, which is to be scheduled in the month of February. And the organizing committee has issued number of presentations, but most of the presentations are from the non-members. So we request all the members to actively participate and send as many as presentations to the committee so that we can give proper representation to the neurosurgeons in the Maharashtra and Goa in our conference. So I will request the moderators, Dr. Suresh Sankla and Dr. Kishore Chaudhary, to start the webinar. Thank you.
Suresh sir, I think you're on mute.
Okay. So, can you hear me now?
Very much we can hear you now.
Okay, fine. So let me start again. Good evening, everybody, and welcome to this pediatric neurosurgery webinar. This time we chose pediatric neurosurgery because pediatric neurosurgery has not been discussed for a long time on our this webinar series platform. For today's program, we have chosen very good pediatric neurosurgeons as our speakers and senior pediatric neurosurgeons as the panelists. So without wasting much of time, let me invite the first speaker of our this session, Dr. Sonal Jain. She is a pediatric neurosurgeon, basically trained from KEM Hospital, and then had her training in USA and many other places. And she is now practicing at the SRC hospital, as well as Surya Hospital in Mumbai. She is a very well established and a very coming up pediatric neurosurgeon in the city of Mumbai. Dr. Sonal, please take over and share your screen and start your presentation.
Thank you so much, sir. At the outset, I would like to thank Suresh Sankla sir, Udayanda sir, and all the members of MCNS webinar committee for giving this opportunity. And without further ado, I would like to start my talk on the topic How I Do It, VP Shunt, in the MCNS webinar number 7, Pediatric Neurosurgery. You can see my screen well and hear me well?
Yes, please go ahead.
Okay. So a little bit about myself. I'm a mother and a passionate pediatric neurosurgeon. More about the exclusive pediatric neurosurgeon in me. So I've, as Sir rightly said, I have trained from KM, born and brought up in KM, my undergraduate general surgery and then MCH neurosurgery. And then after a few visits back and forth to the US, I could finally convince them to take me as a hands-on clinical fellow. And so I was a fellow with Dr. Raghib and team in Nicholas Children's Hospital, Miami. I trained there for pediatric neurosurgery, epilepsy surgery, and now I'm back in our country to try and help as many kids as possible. Rather than saying how I do it, I would like to eat the humble pie and say that how I have come to do the ventriculoperitoneal shunt, and there might still be some mistakes. I'm outfront sorry for those, and I hope that together with, as Suresh Sankla sir said, with juniors presenting and the seniors commenting on them, I hope that we reach to an optimum technique today. So a small story many years ago, just like a small kid fiddles around a working mom, letting her work, asking her questions, and still try to be around. That's the exact similar situation that used to happen with me and Muzumdar sir in KM neurosurgery department, with us trying to be in his office with bunch of scans, trying to ask questions, brainstorm sessions. And one of these sessions, he introduced the term pediatric neurosurgeon to me. And we were talking about Dr. Jeffrey Blount, when he said that those are the surgeons who, at hearing the name of hydrocephalus, hold their head and they're like, oh my God, VP shunt, oh my God, hydrocephalus. And at that time, as a naive resident, I couldn't quite fathom the importance of hydrocephalus and VP shunt, because it was a procedure which was very willingly given to us by our second year residents when we just joined neurosurgery. So I couldn't understand the depth, the importance of it. But today I understand the implications of one shunt infection. One surgery lost, another surgery to remove the shunt, a prolonged time of IV antibiotics, which unfortunately in a small child means a central line or an axis or stay in the ICU. The stay gets complicated by a fungal infection, unfortunately. If and when the child is infection free, the child gets another shunt, which is a second surgery at least. And then there's a high risk of failure because inadvertently they have failed. If adhesions come in, ventriculitis comes in, multi-compartment hydrocephalus comes in, it is a disaster. And after all these efforts, we are left with a decreased IQ child, with a developmentally delayed child, an unhappy family, definite financial issues. And now when we are in the private world, invariably we end up losing the patient to a government hospital, and we lose up connecting with the entire family. So it is definitely as stigmatizing, if not more, like an epilepsy patient where the whole family is affected by it. Most of the times one child is at home, the family is here, the parents are here. So there is no way I can underestimate the importance of a shunt now. And I totally understand, as Dr. Rekat will also mention, that first shunt is the best shunt. The shunt is many a times a nightmare for many pediatric neurosurgeons, but undoubtedly it is a very high impact surgery. In India, given that 67,000 children are born every day, and according to AIMS New Delhi, the incidence of hydrocephalus is somewhere around 0.2 to 0.5. We have almost 100 children born every day in India with hydrocephalus. The incidence of post-infectious hydrocephalus and all is still more. So it's a definitely large disease and a high impact surgery when we speak about shunts. No shunt surgery webinar or presentation can go without mentioning Dr. D.K. Chabra, and I have taken in many inputs from his paper. And when possible, I do use a Chabra shunt, a low pressure shunt or a medium pressure shunt, unless it is a child with an open fontanelle, that we would try and use a programmable shunt. And in his paper, Dr. D.K. Chabra has very well mentioned in 2019 that he's very concerned that in today's neurosurgeons, the shunt surgery is an emergency, low priority procedure performed by the doctor who's lowest in the hierarchy of the department. And often the doctor himself, it's not a mistake, but it's just the innate nature of that doctor, that his skills and responsibility required for long-term success of this surgery is not comprehended well. So I totally understand and believe and support that we are beginning our MCNS pediatric neurosurgery webinar with a how do I do it VP shunt discussion. So I would like to touch upon the following points throughout my presentation. Before touching the patient, once the decision is made to put a shunt, the patient comes on table. After touching the patient, before touching the shunt, and after touching, or rather not so touching the shunt. So before touching the patient, some basic things we all do in history, examination, imaging, and investigations. But I would like to stress upon here the importance of CSF sampling, especially in children who come to us with large heads, because invariably, if there's a history of NICU stay, premature baby, low birth weight, any other infection which has come and gone by in the passing, these children do not present with a black and white picture of communicating versus non-communicating hydrocephalus. We have seen patients with COX, with fungal infection, with partially treated meningitis who develop an aqueductal web and come with aqueductal stenosis, but they are in fact infective patients. So a CSF sample is very important, especially before we decide to put in a artificial hardware in these children. Once we do decide to put in a VP shunt, it is very important as a neurosurgeon to run through the following list in our mind to know what are we exactly doing. So which shunt valve to use? There are about 40 valves available, but as Dr. Wolf et al. Proved in Uganda through their randomized trial in 2005 that there is no difference between the programmable Codman-Hakim valve and the Chabra valve. As I mentioned, I try and use the Chabra shunt as and when possible. Antibiotic impregnated versus plain shunt. The HCRN committee has come up with a new protocol that antibiotic impregnated shunts should be used. Bactiseal shunts have recently been introduced in India. So as and when possible, they should be used. I know that some of the senior surgeons here use a hybrid technique of using antibiotic impregnated shunts with the Chabra valve. So those are the few points that one should ponder over before considering a shunt. The entry point for the catheter, which side to put a shunt, equally important. The entry point for the peritoneal catheter, the length of the catheter, the scalp preparation. The preparation before the surgery is done begins in the ward for the child and in our minds way before the surgery is done. So a good head bath, overhead shampoo, and then next morning preparation in the OT. These three steps are extremely important to prevent shunt infection again. And I would just touch upon any sophisticated measure which is required in addition to the usual technique. And shaving as a norm, we do not shave the patients before surgery in the ward. A complete head shave is not needed. Just the amount of hair needed to remove is clipped on table. And then if there's any existing central line, it's usually a point where the PICU team and the neurosurgeons need to communicate way before in advance. They should be telling us that they are planning to put a central line, or we should be reaching out to them, telling them that we need to consider putting a shunt in, because invariably the right IJV or the left IJV or some puncture marks are present here, some fibrosis comes in, some infection sets in, and it's a problem then. So active communication once the decision to put in a shunt or a potential decision in the next few days possible for a shunt required exists, we should be communicating with the entire team from pediatricians to our ICU to our OT as to where the central line goes to, which shunt needs to be used the next day on table. Evidence regarding which point to use as an axis. All of us are familiar with mainly the Cockers, Keynes, Fraser's, and Dandy's points. There are many other points available. It was our regular practice, rather in residency days, that we used to use the Keynes point or the Fraser's point, and I'm comfortable with the Fraser's point, or second preference to Keynes. I know many would do the other way around, but those are the 2 points I'm comfortable with, familiar with. And evidence also says that frontal shunts invariably can can come out to be small in children once they outgrow, and hence we should try and get an parietal or an parieto-occipital shunt if and when possible. So my preference, as I mentioned, is a Fraser's point, which is 6 centimeters from the inion and 3 to 4 centimeters off the midline, entering to the parietal bone and going in through the occipital horn and all the way up till the front. To the frontal horn, essentially because the frontal horn does not have choroid plexus, and it's a straight trajectory, whenever possible the longest trajectory available. Again, evidence for repeated shunt infections were extensively studied abroad. And this is a very interesting paper where one of the names of the publishers, as you can see, is RN, a registered nurse. And this nurse typically used to sit in the OR of Sick Kids Toronto. And her only job was to use a checklist and keep ticking what all things the surgeons do. And based on her data collection, they've come up with one of the first few premier papers about shunt infections and shunt failures in pediatric patients with hydrocephalus. And this is her checklist that perioperative variables were recorded: the age, the length of pre-op stay, the previous shunt, the priority level of operation. As Dr. Chabra mentioned, that in most of the cases in India, it's an emergency surgery, but then it really matters whether we give this the highest priority because this is a small child, hardware surgery, infection being a huge problem, or we keep it as an emergency surgery just because the person who's doing it qualifies and deserves to get the emergency OT. And then the intraoperative variables. So again, this nurse used to just sit in one corner quietly and keep ticking these points. Use of prophylactic antibiotic agents within 30 minutes, total number of people present in the OR anytime during the surgery, presence of holes in surgical gloves. They used to actually put water and see whether the gloves have holes, number of times the shunt system was exposed or to the gloves. So there's a no touch technique which is highly recommended, which I would come to soon. Number of times it was the shunt system was manipulated by an instrument as against by a glove, use of ultrasound, endoscope or any adjunct. And some other very interesting points which were noted by the nurse were number of holes in the drapes. Surgeons have this habit of putting staplers, multiple staplers anywhere and everywhere they can. But this study actually objectively documented that the lesser the number of holes in the drapes, the better. And so invariably now what we do is we overlap the drapes, and where the overlap is, we just put a hole there which doesn't reach the skin to prevent trauma to the skin and to prevent a frank through and through hole in the drape as well. They also mentioned the number of people incorrectly donning, meaning wearing the head cover, mask, or gown. Interestingly, shoe cover does not change the outcome of shunt surgery, and it's a routine practice abroad as well that they walk in the shoes which they normally wear in the hospital. However, I think it's a good habit for us all to change our slippers coming up from inside and around the OT at least. And then the number of times the light handles are contaminated. I would just come to this point when I come to the point of how I would rather drape and prepare the patient for the surgery. So based on these few articles, I would now like to speak about my preference for the surgery. And invariably, any VP shunt presentation needs to involve now the HCRN protocol, which is the Hydrocephalus Clinical Research Network, which is a group of independent neurosurgeons across Canada and US who've come together, pool in their data, and then give evidence-based guidelines about how to reduce infection, when to use shunt, when to use ETV. So again, this is evidence. We have to take it with a pinch of salt when it comes to our country, but nevertheless, these are few good guidelines available around. So like they have extensively mentioned, there was a protocol, 11-step protocol in 2011, which they have further modified to now involve antibiotic impregnated catheters. So IV antibiotic is typically requested before incision, just 30 minutes before. Invariably in most of our hospitals, the anesthetist proudly tells us that the child has received antibiotics in the ward. The child is already on antibiotics, but still we have to request for a skin cover. So just 30 minutes before the incision, a simple antibiotic like cefazolin, or if the child is allergic to cefazolin or is a known MRSA carrier, we can consider vancomycin. They apply chlorapep. A good combination is beta scrub and microshield alternating. Wait for 3 minutes after betadine is applied. And here I get a lot of resistance, especially from the staff. Dr. Chaudhary sir is trying to say something. So we can't hear you. Should I continue, Dr. Sankla sir?
Yes, your time is getting over. That's what he's trying to say.
Okay. So basically, Okay. Basically, try and cover the antibiotics. So I'm just giving evidence to how I do it. And later, I've just mentioned the steps of positioning and preparing the scalp, umbilicus. So every step needs to be done in a very meticulous manner, essentially, is what I want to stress on. And otherwise, antibiotics to be given mark site, first scrub, second scrub, doning, very, very important because every step is related to infection. And then the incision abdomen is typically opened in layers. A 4 mosquito technique I used, and change blades in between. Once the shunt is introduced, need to be very careful that we don't touch any element of the shunt. Typically handle the elements with a gauze piece or shouldered forceps. In India, I make the shouldered forceps using the simple white tube which connects the connectors. And the ventricular end, introduce it with the stillet first. Then once the giveaway is obtained, remove the stillet and then try and reach the frontal horn, avoiding the temporal horn. The way I do it is point it towards anterior superiorly and slightly medially rather than posterior inferiorly or inferiorly. And once the whole system is connected, we fix the catheter to the subcutaneous tissue. I know there are advantages and disadvantages of the same, but this is something I've learned throughout my teaching and residency. And after the shunt is inserted, the closure is also very important because there shouldn't be any needle pricks on the catheter. So very precautious closure is important for the skin and subcute. And an X-ray post-operatively is very important to give us an idea of how the shunt is placed. Sophisticated adjuncts that we have come to use are neuronavigation, neuropen, which is a shunt with an endoscope inside the shunt, endoscope assisted, laparoscope assisted in the abdomen, and humble pie, revise if any doubt. I owe my knowledge to most of these people. Thank you.
Thank you. Thank you very much, Sonal, for explaining the shunt and describing the technique so nicely, and very fine points that you tried to say.
Thank you, sir. Sorry, sir, I'm not able to hear any of you.
Dr. Sankla, your voice is muted.
So what I was trying to say that you did a wonderful job in describing the technique and explaining small points which are so important and yet necessary to all of us to know, how to take care of the shunt surgery. So we'll discuss more about it in the end of in the discussion panel discussion.
Thank you, sir.
And thank you very much. Let us move on to the next speaker, and may I invite Dr. Sawant. Yeah, Kishore, you want to say something?
Kishore, something is wrong with your voice.
Kishore has swallowed a frog.
It looks like, yeah. Kishore, we can't hear you properly, so check your speaker.
There's something called Kawwa Biryani, in one Hindi movie, Kawwa Biryani eats.
Sushil bhai.
Just check your speaker and the sound system there, and we move on to the next speaker. In the meantime, let me invite Dr. Saurav. Dr. Saurav Samantre is trained from Hinduja Hospital, and then he went to UK for his...
Is that better?
Yes,
yes,
That's better.
Now it's normal.
So let me invite Dr. Saurav. Saurav, are you around? Oh, yes, I can.
Yes.
Yeah,
Yes.
please join the screen and share the screen and continue your talk. Dr. Saurav, please.
I am, yeah. So is my screen seen well?
Yes, perfect.
Thank you. So at the outset, I am really thankful to everyone in the MCNS committee for giving me this opportunity. Many present today are my teachers and also many colleagues, and therefore I take this as a privilege to be talking to you all. So without further ado, I think I should jump on to the topic, which is myelomeningocele and how I do it. My name is Saurabh Samantra. I'm a pediatric neurosurgeon and an epilepsy surgeon. So in the last 6 or 7 years, I've been dedicatedly doing only pediatric neurosurgery. I started my pediatric neurosurgical journey in Wadia Children's Hospital, where I worked for close to 3 years. Then having spent the last 2 years in the UK at the Great Ormond Street Hospital and the Birmingham Children's Hospital, I'm now a consultant at SRCC Children's Hospital and Jupiter Hospital, Thane. So anyways, I'm assuming there would be a few residents today, and hence I'm flashing a few of these images. What we are seeing here are 2 different neonates with lesions, with open neural tube defects on their backs. And as we all know that everything gets called an MMC, and therefore I thought I shall include this and some other common presentations which are also seen in neonates. Now, if something like this comes up in a neonate, very commonly in many hospitals, this will get termed as an MMC. Unfortunately, these lesions, these pathologies are very, very different embryologically, morphologically, and therefore that treatment also varies. So on an MRI, this lesion is not actually an MMC. It is in fact a saccular limited dorsal myeloschisis, which is very, very different from a myelomeningocele, which is a disorder of primary neurulation, and hence the whole surgery and the embryology changes. Again, another lesion, of course, this is an older baby, but if this baby came to us in the first 1 or 2 days of life with a big swelling on the back, many times erroneously it gets termed as MMC, but this is not a myelomeningocele. In fact, you will see here classically described as a terminal myelocystocele. You see the cord herniating out of the spinal canal. Then you see a sac within a sac appearance, a dilated subarachnoid space. So again, this is a terminal myelocystocele warranting a completely different approach. And also the whole formation and embryology is very different. So, for the residents, I think this is quite critical to know that all lesions in the neonatal period, which look like they would impendingly rupture, are not necessarily myelomeningocele. Having said that, let's move to what is a myelomeningocele. Like we see here, this is a myelomeningocele. Now, there is another entity called a myelocele. So what is the difference between a myelomeningocele and a myelocele? Like we see, the placode here, where my cursor is the placode here, which this arrow points to. Now, this placode is actually a tube which is now open like a plate. Now, as we can see in this baby, in fact, this is a baby that I operated 2 weeks ago, about whom I'll be discussing in my later slides. You see that the placode is pushed up beyond the normal skin, as in this illustration. This is a myelomeningocele where you have a dilated subarachnoid space. What is also very, very critical to understand in the morphology of a myelomeningocele is that if you see, this is of course an illustration, these lateral rootlets here are actually the dorsal rootlets, which should have been on the dorsal aspect of this placode if it were tubularized and if it was a normal spinal tube. So therefore, we have to remember that in a myelomeningocele, the lateral most rootlets are actually the dorsal rootlets, which could not reach their location because of the tube not converting into a the placode not converting into a tube. And this is a myelocele again, where you do not see a dilated subarachnoid space. So again, you see, this is the neural placode, and this is called the junctional zone, which is where, which corresponds to this on the illustration. So you have the meninges, the leptomeninges coming here, and then you have the normal skin, and then the dystrophic skin all joining here, leading to the placode. So these definitions are very, very important when we talk about repairing a myelomeningocele. A very brief mention of why does a myelomeningocele form. Like we know, there are 3 major stages of embryology of the spinal cord: gastrulation, primary neurulation, and secondary neurulation. The primary neurulation is responsible for the formation of the spinal cord up to the S2 level, and it takes place between 3 to 4 weeks. What happens in primary neurulation is that the same layer, so in fact, what is interesting is the same layer forms the cutaneous ectoderm and the neural plate. So therefore, if you go back, the skin and this, the myelomeningocele, no better example than a myelomeningocele to show how the skin and the neural tissue have all derived from the same layer. And in fact, this aberration in itself demonstrates embryology so beautifully. So, gradually this plate turns into a tube, and then it pinches off here, which is called disjunction, forming a neural tube and a skin above. When this whole embryology goes haywire, we have this, where there is an open placode, which is not formed a tube, and therefore, it is open to the atmosphere, and the skin, therefore, has only reached the junctional zone, which I was talking about in the previous slide. So after having said this, just wanted to point out this was the same baby, a patulous anus. This child had dribbling, he had a patulous anus, and of course the child was born paraplegic. So what are the goals of surgical treatment of a myelomeningocele? One, we have to excise the malformed sac. Second, and most important, we have to prevent CNS infection by creating a barrier between the spinal cord and the exterior. And third, we have to restore normal CSF environment around the spinal cord. How do we go about achieving this? By reneurulation and multi-layer closure. These are the two main targets of our surgical approach, our paradigm for treatment. Of course, I would very strongly recommend operative microscope and loops. So magnification is necessary, especially for handling the neural placode. And a passing remark on latex allergy, it is well known in these myelomeningocele babies, incidence of around 15 to 19%. As we know, there is a big incidence for these children to undergo multiple surgeries, especially in their first year of life. And we have come to know that the number of surgeries in the first year of life is the most important factor for sensitization and hence leading to severe allergic reactions. After having said all that, anesthesia and positioning. So general anesthesia, preventing hypothermia is very critical, urinary catheterization, prone position, firm chest rolls, and padding of the pressure points. So, apologies for showing different babies, but I thought this would, highlight the positioning and the padding of pressure points very crucially and very well. So you can see the abdomen here is free. The pressure points are padded. And as you can see, there are 2 chest rolls here. And the rest of the exposed areas of the baby are covered well to prevent hypothermia, which is very critical from an anesthesia and, of course, from an outcome perspective. And we also use the bear hugger for prevention of hypothermia. Now, skin preparation. How do we prepare the skin? The surrounding skin is prepared by the betadine solution. So we use the normal 10% aqueous betadine solution to prepare the normal skin. However, we have to be very, very careful that we do not use betadine to prepare the placode. So the placode is generally prepared or prepped using saline and Ringer's lactate solution. We should prep a very wide area laterally because, at times we might have to make lateral release incisions. And also after the placode is tubularized, we have to use and mobilize the skin to achieve skin closure. So prepare more than the malformation. Also prepare superiorly and inferiorly because we have to accommodate the extensions of our incision, which I will be showing you in my next slide. And drape with Ioban on all 4 sides. Make it a point to separate the anal and the perineal regions from the operative field. Now, this is the incision once again. So what I'm doing here is a vertical midline incision. We should expose 2 rostral normal vertebrae. I will highlight why that is important. So therefore, this vertical limb of incision on normal skin. Then the junction between the dystrophic skin and arachnoid. This is where, so it is like a vertical midline and then an elliptical incision converging again downwards. So basically, you have circumferential extension of this incision all around the placode between the dystrophic skin and the placode. Be very careful to save all skin for the closure. We might at times feel that this skin might not be useful for closure, but there have been many occasions when we have sacrificed this skin and later on repented our decision of sacrificing the skin, because the skin which looks dystrophic later on is quite resilient and helpful in skin closure. Vertical midline caudal incision, just to elaborate the caudal normal anatomy, which helps us in orienting ourselves to the malformation. Now, after having taken the incision, the neural placode is isolated. So as you can see, you have to be very gentle in handling the neural placode. Dissect free from all the arachnoid membranes. The placode has to be dissected free from all the arachnoid membranes. It is advisable to begin at the upper limit and then go circumferentially all around the placode. Proceed circumferentially. You have to be careful at the borders of the placode. So if you remember, I had showed you the previous slide where dorsal rootlets are in close proximity to the lateral border of the placode. So therefore, when you are handling it, we have to be very, very careful that we do not end up damaging the dorsal rootlets in those babies where they might be functional. Also, this is a very key point, meticulous removal of all dermal and epidermal elements, because delayed dermoid and epidermoid cyst formation is known. So if you were to leave some portions of this skin on the placode, this can lead to delayed dermoid and epidermoid cyst formation. So we have to be very, very meticulous in removing all skin. Sharp dissection using micro scissors is preferable, and avoid bipolar coagulation as far as possible so that you do not cause any damage to the placode and also to blood vessels which might get thrombosed. Now, like I was telling you in that illustration, you can see here that now I've tried to bring both lateral margins of the placode in the midline, and we can see the dorsal and the ventral rootlets. So basically, phylum terminale sectioning. So it is always advised that after the placode is seen, look for the phylum terminale, because if you can see the phylum terminale, you can section it in the same surgery, and this prevents secondary tethering. So therefore, look, in our case, in my case, I did not see a phylum terminale, so therefore I had nothing to section, but always look for a phylum terminale because this can cause secondary tethering. Aberrant nerve root sectioning. Now, these nerve roots are, of course, non-functional in my case, but there will be some nerve roots which start from the placode and end up in the dura. So basically, they have no target really. They're not supplying a dermatome or a myotome, and therefore, if you they are only causing tethering. And so if you section the aberrant nerve roots, you will prevent secondary tethering. Large vessels entering the ventral surface of the placode do not coagulate, like I said, because if there is any neurological function remaining in this placode, in kids who have some function remaining in the lower limbs, this will cause thrombosis and neurological decline. Also, again, inspection of the dural sac. After having seen the malformation, inspect the dural sac to look for other malformations. There can be coexisting dermoids, lipomas, and I remember from one of my days in fellowships, in my fellowship at Wadia Hospital, when I was doing a myelomeningocele, I ended up finding a hemimyelomeningocele, and there was a bony spur. So remember, this is very commonly known. So always inspect the dural sac for any other coexistent malformation. Now, this is a small video of how the reneurulation is done. So, as you see, I'm using a 5O monofilament here. There's a 5O proline. So what we have to do is, you can see the needle going through the pia arachnoid of one side. And I have to try and approximate the pia arachnoid of one lateral edge of the placode to the opposite, the contralateral pia arachnoid border. And as far as feasible, try to see that your knots are buried. As we know from Dr. Daklingpang's description of lipoma.
I'm sorry to interrupt, Saurabh. 3 minutes left.
Fair enough. I'll be finishing, sir. Yes. So preferably buried. So neural tube reconstruction, you can see the whole neural tube is reconstructed and all these roots are preserved. The lateral edges of it are approximated. Pia arachnoid border is sutured. 5O proline is what I use, a 10 mm round-bodied needle. Placode is, so basically the intention of the reneurulation was that the placode is converted again into a tube with normal leptomeningeal coverings. Reneurulation facilitates dural closure. So therefore, it's very important to reneurulate, and reneurulation also prevents secondary retethering. If the placode is too bulky, though, at times we can abandon this step. But at all costs, we have to try avoiding dural compression due to excessively tight closure. So excessive tight closure is avoided. Now, after this is done, you can see this is the dura. So remember, now we have to start mobilizing the dura. And this is after the dural closure. The dural closure is done with continuous sutures and the thoracolumbar fascia is now seen. So dural closure again, the points are start dissection from the rostral end, find the normal dura, find normal epidural fat. This will facilitate a plane of dissection. Dura is thinnest as its lateral margins. Watertight closure is preferable. Continuous sutures is what I prefer. And again, avoid neural compression due to tight closure. Dural substitutes at times can be used, both autologous and synthetic. Again, this is the picture actually I've taken from this beautiful paper by DiRocco. So facial closure, you mobilize the facial flaps, lateral release incisions and midline approximation. Sometimes, there can be double breasting of facial flaps. Free facial graft can also be taken from the cranial end. And sometimes the facial flaps can be integrated. So you can actually peel off the periosteal flaps from the lumbar pedicles and the bifid lumbar pedicles in transverse processes. This is the final skin closure. Again, undermine the skin. Sometimes using digital manipulation, it is very, very safe. What is important is do not coagulate perforators to the skin. Subcute layer, remember, is thickest at the junctional zone and thinnest at the malformation. You have to have some subcute beneath the skin. Otherwise, you will cause, very thin and stretched out scars. So take subcute stay sutures, pull the subcute layer closer, and then use the skin. And that is why I was saying do not compromise or lose any skin at the beginning. But remember that subcutaneous layer should be present beneath to avoid scars. And sometimes large defects might need flaps. This was only another interesting point which Dr. Pang had brought up when I was at the GOS with him. He at times in completely paraplegic children advises excision of the neural placode. And the reason for excision of the neural placode is multifold, as he says. One, it makes dural closure very easy, which is very logical. Since we omit the step of reneurulation, we excise the whole placode, and therefore there is no chance of leaving any dermoid or epidermoid, late epidermoid or dermoid formation, because there's no chance of leaving any skin elements inside. And third and most important, by excision of placode, you can convert a UMN bladder into an LMN bladder. And as we all know, an LMN bladder with CIC is more easier to manage, and also there is less vesicoureteric reflux. So this can be considered in children who are completely paraplegic and doubly incontinent. Thank you all so much for your patience, and I'm so sorry for having overshot my allotted time. Thank you so much.
No problem. Thank you. Thank you very much, Saurabh, for this brilliant presentation. I think we'll take questions after all presentations are over. The next topic is equally interesting.
Sure. One suggestion.
Yes, sir.
Yes, Sushil. Just be quick, please. Hello. Can't hear you. No, I think we lost him.
Suresh, I think you can continue.
Okay.
Yeah, I think
so.
Can you hear me?
Yes, we can.
Yes, sir.
Go ahead.
We can hear you, sir.
I think this is no conference, and these guys have worked hard. Don't restrict them with time. Let them keep talking, because the pressure of completing can sometimes end up in giving up some important discussion.
Yeah. Okay. Thanks. So the next topic is very important, and we very often come across these kids with the spinal lipomas. The topic is so confusing, and the literature is also not very clear on spinal lipomas in small kids. So to cover that, I would invite Dr. Biani. Dr. Biani, please share your screen and start your presentation. Spinal lipomas.
sorry, Naresh, before you start, because I have restricted the first two speakers, I'm sorry. I will remind you at 12 minutes and 15 minutes as well.
Yeah. That would be much before time, actually. Don't worry.
Okay.
I'm
Thanks.
also a big fan of restricting to the time limit, actually.
Okay.
Go ahead.
Good evening. This is an operative how do I do session. So in next 15 minutes, what I'm going to speak is lipomeningomyelocele, what is the clinical and imaging, surgical tricks. We are like Abhimanyu entering the Chakravyuh, and what it comes to mind is the closure, facial closure, dural closure, and finding the DRZ. And from a surgeon's point of view, stratification and risk, what are easy ones, what are the difficult ones, So this is a clinical picture. Okay. So this is the antenatally diagnosed lipomeningomyelocele with a huge swelling, weakness in the left lower limb. And this is the imaging that the child has. So one can see, let me start the pointer. Yeah. So the spinal cord is coming here, is ending up in the plaque cord. This is all lipoma. This is the meningocele defect. And then this is a lipoma also. Okay. And there is a myelocele element. We can see the nerve roots coming out of here. This is a sagittal imaging where this is the normal muscle plane, and here we can see that whole placode is open. The right side we can still see a dura. Here there is no dural layer. Then there is an abnormal bone that is present over here. There is no carry herniation, and then mite syrinx over here. The most important point here is to see a junction of the dura, the nerve root, and the spinal cord. Here we can easily see there is no dural or spinal cord junction. So the right side is easy. Here it is all very difficult, and that is the most important. From a Abhimanyu point of view, we need to have a good closure. This is the same thing. When we have this complex lipomas, what I also like to do is a fat suppression sequence where the fat is blackened, and here you can see there is a phylum terminal, that was totally overlooked in a T1 or T2 weighted images actually. So this is how the child is intubated in a lateral position. We don't want mass to be under pressure. This is adequately padded all the pressure points and good two peripheral line. This is the lateral view. The hypothermia is one of the biggest problem. So the child is accurately covered, and this is the neuro monitoring that has been done. And this is how I cover the child. This is what we call as a waterproofing, where the child is waterproof from the surgical saline irrigation, and also a blower is underplaced, and that is kept at the body temperature to prevent overwarming. Okay, when I prepare, I make sure that the solution is warm. It is already kept in the warm saline so that we don't cause hypothermia. This is what is preparation is done. Always we use the IO. This is the incision that has been made, elliptical, going right up to the top of the meningomyelocele. Now, the subcutaneous lipoma and the lipoma of the cord is always different. When we start doing that, here you see the lobules are much bigger, and you can find always a line. This is the deep fascia under which the lipoma is there, and this is all because of the embryology. This is on the right side, and then from the opposite side again we find the bands. You can see the strias here, and once you open that facial layer, this band starts popping out, the fat, and that is shows that it was under pressure. We open up. Slowly a plane is dissected. I do it with cautery. A lot of people, they would do it with the blunt dissection and scissor. And at places we have to be careful. Here there was no lipoma. This is the meningocele sac that we are seeing. Slowly, round and round we try to go. And once we find a margin, so this is the margin where the bone, the muscle, and the bone, the spinous element is ending up, and this is the place till where the dissection is made. Now the sac is opened, and after opening the sac, I put a cottonide and drain the CSF. It has to be gradual, and after that, the more opening is made. This is how the nerve roots would be seen. The nerve roots here, few arachnoidal bands, and then this is the placode with the lipoma. The most important thing over here is to identify the lipoma, the cord, and the DRZ junction. And that what would define it. These are the fibrous bands, arachnoidal bands that are sharply cut with the micro scissor. So you can see that this is the nerve root. Here the identifying the phylum, that is fatty over here, quite thick one. And then we'll identify the DRZ zone also. Okay. And on everting that thing, now we can see a layer over here. This is the junction. So all my dissection would be outside that. We don't want to get into it.
In the HB.
Yes. So once that is identified, next the dissection is started, and here the child had a central myelocele also. This was a terminal myelocele. So this is one side of the cord, that was the right side, and now this is the left side of the cord. After having drained the CSF and the myelocystic fluid, then I'll go and try to trace the anterior spinal cord. So this is the spinal cord that is coming out. Now I have to find the nerve roots over here, like similar to that. And now we can put a dissector and can release the lipoma. Okay, now the fatty phylum is last to be released. So it is isolated and then cut. Okay. So after that comes the closure part of it. And now the excess of meningocele sac is used to close the dura, artificial. I don't use any artificial substance. So after that, you see from here, we have so much of excess of tissue, and I need to just make sure that I do a good double breasting. So this is one layer. This is what I put number 1 pen field, and then I know I have to cut at this place, and then I will be able to do a double breasting layer. So this is for the dural closure. The dural I use in this particular case 3-0-prolene, otherwise 4-0-prolene is used. So running suture, locking. make sure that there is an adequate spinal canal and the cord sac ratio is maintained. And then this is final, I go up and then come down back and then tie that off. Now that extra bony spur was lying over here, the extra osseous element. So that is dissected out. And I would use that layer. This is the excess bone that is nibbled out. And that same layer with the muscle and the pericranium, the periosteum of the spur is used to cover the facial defect and make sure that that's watertight. And then the excess skins are excised. This bump is still left out. I don't want to be aggressively excising because if there is a fat necrosis or if there is a delayed wound healing, that would help us and give us a reserve. This is the final dressing that is done. So take home messages. Every lipomeningocele is different. Apples are apples, oranges are oranges. Imaging is the key, During the imaging, we need to see the junction, DRZ, lipoma, and the dural juncture. Dural closure, we think of it when we are looking at the images. Facial closure, we are always worried and make a sure shot plan for it. Now we have a better outcome because of MRI and early diagnosis, early referral. Microscope is essential, neuromonitoring for a complex cases, yes. Here, it was not needed, but if you have a CUSA, it's always good to suck out the lipomas and safe anesthesia practices. Thank you very much.
Thanks, Naresh, for finishing on time and giving a good demonstration of how lipomyelomeningocele can be excised safely and more systematically. Can you, your screen is still visible. Can you unshare your screen?
Yeah.
Okay, so before I invite the panelists, Dr. Udayandar and Dr. Suhas, I would request you to just keep these questions and queries ready so that we can discuss it tonight. We have got still 15-20 minutes time to discuss all the presentation. And let us go ahead with Sonal's presentation now. Sonal, there are going to be a lot of questions from the audience and the other senior persons here present in this webinar. Let me start with one question. What is the final word about the head shaving? I know there are a lot of confusion and a lot of controversies and a lot of studies on this topic as well. What do you think is the best thing to do the head shaving?
Right now, I would say the cumulative evidence points towards doing a clipping on table of minimal hair as required along the incision line. And in the abdomen, we can avoid shaving altogether. Definitely no overhead, whole head shaving by the barber as used to be the practice before. So just clipping, minimal use of the clipper on table, sir.
Okay, fine. I agree with you. Uday, anything for the VP shunt surgery? Suhas?
Yeah, so
Uday, you are muted. Okay. Just unmute yourself. Yes.
Wait, there are two Udays. One is Udayan and one is Uday.
Yes. Yeah. Okay.
Yeah, Suhas, you can go ahead. I'll take on.
You start, sir. I'm okay, sir. Go ahead, sir, please.
Carry on, Suhas. Carry on.
Okay. So regarding the clipping, I am a bit liberal because I want to keep the area clean, and then the dressing has to be well placed. So I prefer a bit of liberal clipping, but not, of course, shaving. That's one thing which I would differ from Dr. Sonu. I think otherwise it was a very, very nice presentation actually to start off. But certain things I would another thing I would differ was using the entry point. The entry point, the classical entry points are probably much more based on the CT era. And presently with MRI, completely available, I would use the MRI to plan my entry point as close to appropriate as possible, rather than sticking on to the standard named entry points. That's how I manage, because I think the MRIs are very good guidance to most optimal point for that particular patient. And then, of course, the entry point, side, etc., depends on that particular patient. So you might have a child who has a prematurely induced hemorrhagic hydrocephalus. So I would look at the larger side, larger ventricle, larger horn, So the configuration of the
Definitely, sir.
ventricles configuration of the ventricles are very important for me. And then at the same time, if it's a sick child, I would look at the constitution and the habitus of the child. You have a large head, a child who is bedridden, I wouldn't choose the standard trajectories or standard entry points. I might even go for frontal as standard for these kids.
True, sir. Yes, sir.
So these are certain things which I would look at. So my trajectory is always, entry is always MRI based. The second thing which I would differ from her was the antibiotic chosen as we looked at the consensus study too. I would look at let's say if I use vancomycin, vancomycin has to be started at least 120 minutes before
Yes,
the
sir.
start of surgery, not 30 minutes, because it's never complete, or at least it might be disastrous.
1 hour before generally, yes, sir.
Exactly, at least 120 minutes. Yeah,
Yes,
1.5 to 120 minutes. So that's acceptable. That's a Lancet. I mean, support to this idea. And then again, sometimes you need to base your antibiotics based on the hospital organism profile, in the antibiogram, and then decide. And cefazolin might not work for many of the many of the centers which we have, where the organisms are usually the Acetobacter, Klebsiella, and so we need to have sometimes a higher antibiotic to start off with, which may not be called the regular prophylactic. I think these are the things which I would tend to differ from the presentation. Dr.
Uday, Uday, any point to discuss?
No, I think Suhas has touched upon quite a few. What has happened, in many of our pediatric cases, we have been using cefazolin, which Sonal mentioned, because especially in Wadia children's, we've been using broad spectrum antibiotics along with amikacin and so on. So the antibiotics, I think the whole strategy comes into practice as per the infection control department in a particular unit or in a particular hospital. From the point of view of head shaving in older kids, as Suhas mentioned, not much. I think subcostal, for the peritoneal end entry, just a subcostal or a little lower than subcostal, never anywhere close to the umbilicus. Please remember, don't go below the umbilicus for any of these peritoneal openings unless there is a real need to get into the pelvis at the second operation, not at the first operation. And as Sonal mentioned, the first shunt is the best shunt. Always, you have to take every pain that you don't have to that you don't get into that shunt again, because it's a pain to keep doing these shunts again and again. The other thing I follow is, if ever a shunt gets blocked, people have a habit of putting a second shunt on the opposite side.
Yes, sir.
This makes the whole thing more complicated, because now you have two shunts to manage. I would rather repair that shunt or change that shunt into a proper working shunt rather than put a second shunt somewhere. So there are a few tricks that we need to remember. The other thing I have used in a Chabra shunt is, the slits that are at the bottom, at the peritoneal end. Sometimes they are responsible for damn things closing down in the peritoneum. I never keep the slit, I just cut it off. The shunt works much better once.
Thank you, Uday. Sonal, you mentioned about the antibiotic impregnated ventricular catheters.
Yes, sir.
System. What is your experience about this? I know there's a lot of literature going on and a lot of controversy. There are lots of papers. They do not agree also. And we have analyzed that whole thing in our Induspian paper on the antibiotic therapy and shunt surgery. What do you suggest? What we should do?
Sir, so my practical take is, if the patient is not affording, then we put a pint of gentamicin in the normal NS, put a catheter in it and use it. If slightly more affording, as Dr. Andar sir has very well used before, we use the Chabra shunt valve with the antibiotic impregnated. So a lot of data still to come up from the Indian evidence factory that we have. But if and when possible, this combination of rifampicin with clindamycin can be used definitely. But many a times we have to go back to our basics and use just simple normal saline instilled with antibiotic. Wash the wounds with antibiotic impregnated NS. That is something which I also try and use so as to avoid infection. So as Dr. Suhas sir clearly mentioned and Udayandar sir commended, that use the infection control committee's decision first, antibiotic impregnated shunts, and then post-op antibiotics to try and avoid shunt infection as much as possible.
And also one more point, don't waste too much time on a shunt. Just finish it quick.
Yes.
Can I ask one
Any-
question? Sonal, quick question. My pediatric neurosurgery colleagues, all of them agree and all of them insist on using a programmable shunt for pediatric population. Now, I know we have restrictions and financial constraints become the problem. But if you didn't have financial constraint, would you recommend using programmable shunts in all your pediatric population? Of course, this question is for
So
Uday
I would
as well.
use.
Yep. Yeah, let
Sir,
Sonal answer, then I'll take over.
Sir, I would use a programmable shunt in a child with an open anterior fontanelle. Keep the pressure low when the fontanelle is open. Slowly step up the shunt pressure over a period of 6 months until the anterior fontanelle closes. I would bring up the child to a pressure of around 110 to 150 and try and maintain that level to avoid slit ventricle syndrome, but to have an optimum drainage as well. Apart from an open fontanelle, in very complicated cases, maybe use a programmable shunt to try and finally deal with the over drainage, under drainage. But otherwise, we have seen that the low pressure the medium pressure chabra shunt works very well. In children with TBM, try and use a low pressure chabra shunt, sir. That would be my take.
Sorry, Uday.
Yeah, so if you ask me, Kishore, I have been pretty lucky that, in my private practice, I come across patients who can afford, these programmable shunts. And as a first choice, I always give the first choice to the parents, saying that, look, this is the best shunt I can use. I can manipulate it from outside. And many of them have agreed. So when I have used a lot of these shunts as a first preference, lots of them, I have been also severely criticized because I discussed them with the parents, saying that why do you want to put a 80,000 rupee worth shunt as a first choice? But I tell you, when you have a programmable shunt, the blockages, the infections, and the complications are much, much less.
Good.
That's right. Yes.
Another question, sorry, Suresh, another quick question to all the panelists and to Sonal as well, that all those Cocker's point and all the points that have been described in textbooks and papers, we all know that we have to confront our own, we have to decide our own entry point according to the morphology of the ventricle, the size, the age, etc., etc. In our setup now in Manchester, I know that it has become compulsory. It has been protocolized that for every shunt entry, you have to use brain lab neuronavigation guidance. I know in my mind that that's not necessary, but to get absolutely accurate placement and accurate entry point, would you recommend it if it was available? Should you use it all the time or every time you use a shunt?
Well,
Can I say something?
You're putting her in a spot. Yeah.
Yeah, Sushil, just let her answer this question. So yeah.
Sir, recently I finished my fellowship abroad and we did not use neuronavigation for every case. Totally agree with Andar sir that we have to keep the time short, do the shunt as soon as possible. So I totally respect the protocols followed in your institute, sir, but would not use neuronavigation in every case. Most of our cases anyways have so large ventricles that anyone can get the access in. So the more important steps are the other steps rather than getting the access in, I would say, but definitely all seniors to comment.
Okay, fine. Thanks, Dr. Sushil.
Yeah,
You were saying something, yeah.
Yeah, I want to add two things. Like Andar said, that you should do quickly. There are a few things which I feel about shunts. One is that never leave the preparation to anybody else. Number two, do it as a first case. And number three, I still follow Circus technique of opening the shunt into a bowl with chloramphenicol.
Correct.
Regarding the shunt passage, over the period of time, I've started using, especially if the fontanelle is not open, I like to cover the patient after I pass the ventricle and do a C-arm image, AP and lateral, and to confirm that the tip is lying somewhere near the frontal horn of the ipsilateral side and are not crossed to the other side. And it is a very simple technique to confirm that your shunt is properly placed before you start your closure.
Yeah.
May I add one thing?
Yeah.
Yes.
We need to have a restricted entry actually, What I have seen in plenty of centers is that people keep on coming in and out, So we need to close the door and have a restricted entry. It's like an implantation and that has to be stressed.
No, absolutely.
Okay.
So the other thing, as Kishore said, all those points which have been described in textbooks, sometimes they go just out of the window because many of these kids have a very differently shaped head. I think it's very important for the surgeon who looks at the MRI scan to have a 3D picture inside the head so that you know in your own head where your entry point is going to be.
Absolutely right.
Having neuronavigation is excellent, but not everyone can afford it.
Yes, Suhas, last comment.
So as sir said, I don't use the navigation unless it's a difficult ventricle, but I keep all my landmarks available in a transparent way. So my eyes are available, the ears are available, and widely draped in IO-band. So I always I take no chance when my catheter is going in. Everything is seen in front of me.
Good. I think that's very important.
Right. Thank you very much. Sonal, there are a few more questions on the chatter box. Please answer them. And
we should answer in the comments in the chat box itself.
In the comment, yes.
Sure, sir.
Now we move on to the next discussion on the meningomyelocele. So Suhas, you agree with Saurav's presentation and the technique. Do you want to suggest some modifications in the technique?
Yeah, it was a very good presentation. I think it's congratulations, Saurav.
Thank you, sir. Thank you.
Yeah, it's a very neat presentation. Now, certain things I would gently additionally add would be, you need to have an antibiotic protocol for these kids because one, they may not appear 24 to 48 hours at your center. It might be gently beyond. So what I usually do is if it is gently later than those initial, let's say 48 hours, I would take a CSF sample always. And the CSF sample goes in and my antibiotic is already started and the antibiotic is stopped only after the CSF culture comes in. And if it is even later than that, I even take a swab out of the surface. I don't know what does it mean, but we have never come up with a consensus on this idea on how to handle children who are gently later than the standard 24 to 72 hours of surgery. And so CSF sample is always a standard for me. Along with, of course, having an idea of how to handle the hydrocephalus at the beginning. If you have an obvious hydrocephalus, when you're operating this, maybe you should be operating or tackling the hydrocephalus at the same time. These are the two things which I would look at differently. And then in the terminology which you used, myelomeningocele and myelocele, another terminology which is very standard is myeloschisis and rachisschisis. So where you have a flat placard without a sac. These are again certain things which are important for the youngsters. Myeloschisis is a very standard term which is used when you do not have a sac. I think rest is, as you said, it's although it looks very simple, it's a very complex in terms of steps, understanding, and as you said, the closure, etc., is very important. And of course, I leave it drain. By the way, I don't know whether others would do it, but I leave it drain because once in a while you will end up with a leak, which might be even technical without hydrocephalus. So I don't know.
Right.
Thanks.
Uday, your comments.
I think we should touch upon something called as a newborn. When they come to our department, sometimes they come with CSF leaks. So there are probably the CSF leaking meningomyelocele should be closed as an emergency as fast as possible so that there is no infection. Saurav has given a beautiful description of how he does it, and I think that's a standard procedure followed almost everywhere. Now, closing the neural placard and all these things, sometimes excising the neural placard as well if it is too large and if the kid is paraplegic, which is very sensible. Now, leaving a drain, I have never done, but I know that some of my colleagues at Great Ormond Street used to leave a drain in. I have never used a drain, and I have not found any great problem. If the kid has hydrocephalus to begin with, when I'm closing the MMC, and if the MMC is a leaking MMC, I would put a shunt in on day one, wait for a day, and then repair the MMC or repair it along with it. So there are ways and means of controlling CSF leak. But I think once an MMC starts leaking CSF, it needs to be closed early.
Right.
Absolutely. That's very important. Saurav, you want to say something about
it? I mean, I agree. I mean, I completely take Suhas sir's suggestions. I mean, I think timing of surgery and treatment of hydrocephalus in parallel with myelomeningocele, I just thought I'll overshoot the time, given. But I agree, these are very contentious issues. So yeah, I mean, what I have come to from whatever little experience I've gathered over the years, I try to avoid a shunt in the first instance unless I'm really pushed against the wall. But then so at the first instance of leak from the wound, I think that is when I tap the fontanelle, send a CSF, and then jump onto a shunt. But if I can avoid a shunt, then I try to do that. But again, there's no short way of doing it. I mean, but I agree what sir is saying. Andar sir is saying, yeah.
What if you see large ventricles on day one?
So, sir, so actually the child that I showed, I wish I could share the MRI. This child had large ventricles, sir. In fact, so and somehow the child hasn't leaked for the last 9-10 days. There has been a bit of a traumatic birth delivery, and hence this child has intraventricular hemorrhage and multiple specks of hemorrhage in the brain. So I put a ventricular reservoir and I'm tapping, but I have not put a shunt yet because the CSF is not ready.
Yes, so you have reduced this ventricular pressure some way.
Yes, because the head circumference blew up after closure. I agree, sir.
Sorry, sir, can I ask you why,
yes,
if there's a overt hydrocephalus, symptomatic hydrocephalus, and
yes,
a
sir.
meningocele,
Yes,
would
sir.
you not prefer to do shunt first before repairing the meningomyelin?
So, sir, I mean, so again, if it is an overt hydrocephalus on imaging, now so again, if I play the devil's advocate, the only argument against putting a shunt, but again, nothing is proven, is if say the myelomeningocele site is infected and I put in a shunt, I'm pulling in fluid from the lumbar CSF into the ventricular CSF, and so I may be promoting I'm facilitating infection. That is the reason maybe I would still wait. But yet again, I agree that puts my wound at risk. And so, and like Andar sir said, once the wound starts leaking, and then it's a whole cascade where, everything from wound necrosis to then we have an infected picture. So I don't know. I mean, yes, overt hydrocephalus with a bulging fontanelle, maybe I would still consider. But if there is not a bulging fontanelle, I would try to avoid a shunt. That's it. That's just an intuitive thought that I have. I don't know what everyone would feel.
Correct. Naresh, I think he just left just now.
Naresh is celebrating the Christmas Eve.
Hi, Naresh.
No. Somebody came at home. I'm just opening the door.
All right. Yeah. What is your take on this CSF leak prevention in the patient who had little overt, ventricular size, which really needs consideration?
No, now we are mixing up two things actually. One is child with hydrocephalus and child developing hydrocephalus after the closure. Okay. So I'll take it the simple one first. The child didn't had a hydrocephalus. We repaired the meningomyelocele, and then he started having hydrocephalus. I would do a ventric tap. If the ventric tap is clean, not infected, the child states get into a shunt. If the ventric tap is infected, then of course we put in a reservoir, make sure that the child is given appropriate antibiotics, and then cleared up the infection, and then child would need a shunt. And if you have a child with a large head, unruptured meningomyelocele, shunt surgery and meningomyelocele are done together in one setup only. So it's a total protocolized way that is being done. There's absolutely no confusion. We create confusion.
Yeah. All right. So Kishore, that that answer is quite acceptable. Correct to you?
Yes, it is. Yeah, all the answers are acceptable, more than acceptable.
Okay. Anything else for Dr. Saurav and Dr. Naresh?
One thing I'll add.
Yes, sir.
I feel just as everybody kept on talking about hypothermia, we have to remember when we operate these neonates, we must always have blood ready. Blood for blood is the dictum. And I have burned my hands once for not having kept blood ready. I don't know what is be more careful, because you have to avoid too much of coagulation, but you must have ready in the theater when you operate infant neonates, especially, number one. Number two, I feel that in most of the dissection, a very good trick which I had learned from a plastic surgeon was to liberally infiltrate saline at the junction between the skin and the arachnoid, and similarly to dissect the dura from the opened out dura and even the fascia. It saves a lot of bleeding. So I think in small children, bleeding is a very big risk which can suddenly turn the table against you, because as it is, you begin with a pulse rate of 120, 130, and suddenly it can go out of hand.
Right.
One more question to you, Saurabh.
Yes, sir.
And of course, Naresh, and maybe comments from Uday. Both of you have shown examples where you've taken a vertical incision, straight incision.
Right.
Are there no incidences that you could take a transverse incision, or you just decide case by case depending on the size, shape of the meningomyelocele? What is your comment on that?
So actually, sir, serendipity, I was thinking of asking this to the whole panel because on what everyone's take is on taking a transverse incision. Somehow I have always taken vertical incisions. Like I said, exposing the dura from the rostral normal end helps dissection. And also somehow the closures have always happened with vertical incisions, but I know that transverse incisions are practiced. I have no experience in using transverse incisions. I don't know what everyone feels with their experience.
Done transverse incisions.
No. One has to understand the skin supply is from the lateral part, and in an already compromised skin, taking a lateral horizontal incision is never good. Pediatric surgeons have been taught and they keep on doing that. The another disadvantage of a transverse incision is that suppose you have another associated abnormality, or where you have to dissect one level up or one level down, that is restricted. But in an vertical incision, you can go 2 level easily, release the muscle, do a nice laminotomy and come out. So if you understand a surgical principle, midline is supplied from laterally from 2 feeding arteries, lumbar thoracic arteries, and vertical is more anatomical.
I agree with you, but many a times, Naresh, we find lipomas or meningoceles which are lateral, they extend horizontally.
No. Andar sir does a lot of this lumbar. The case that I showed, probably Andar sir would have done with the horizontal incision.
Yes, I would have done a horizontal smiley.
I have assisted him. Yeah, I have assisted him.
Horizontal smiley on that.
I agree with.
It's a nice bikini incision, and the only thing when you're doing a horizontal incision, the only thing that you need to really remember and never do it is dissect on the buttocks, because the lower end of the incision is entirely supplied by vasculature, which comes from the gluteal muscles into the skin and up, from down up. So if you dissect the gluteal area very desperately in trying to pull the skin up, you're going to destroy that incision completely. Never dissect it. And whenever you dissect and whenever you want to release the skin on either side, please leave the subcutaneous fat as it is. Don't go above the subcutaneous fat. Don't be, subcuticular when you're dissecting. It's very dangerous and it can actually destroy the entire incision. That's the only thing. But I have taken a lot of horizontal incisions, not in every patient, but as per the lie of the lipoma.
Yes, I completely agree with you. I also do the same. Another interesting thing is the case where you find a lot of deficiency in dura, and the dural closure becomes difficult. So, what substitute do you use? Saurabh and Naresh.
Go ahead, sir.
Can I answer that question? Actually, I was meant to ask the same thing. But I would just add to that question that if autologous tissue was inadequate to cover the dura, what other non-autologous substitutes would you use?
With Dachling Pang, when I was with him, he is a big fan of a Gotus patch, actually, pericardium, bovine pericardium. I have been seeing him using liberally for almost all cases, but I don't use it. I'm able to find a lumbar fascia and autologous tissue to close it. I have seen a severe reaction with the G patch that is available. I've seen a lot of neurosurgeon operating doing that, but it is the more reaction it causes, So prefer to use fascia lata if nothing is available. But again, fascia lata in a small child that becomes a slough. So it is not better to avoid and find a lumbar fascia, And that is where Abhimanyu comes into picture, where we know where we have to make incision and try to keep as much as lumbar fascia and dura to repair it.
Yeah, I think that's a good suggestion. Lumbar fascia is one of the best. And now there is some kind of a dura which you can actually stitch over. There's a synthetic dura which comes.
Yes, and that has got some Duragen properties also. So
yes,
sticks also at the same time you can stitch it.
You can stitch it
so
and make it waterproof.
If it is available everywhere,
But quite expensive. It's almost 20,000 rupees for a small little patch, 2 by 2 inches.
Okay, Saurabh, your word, and then Sonal.
No, so I agree, sir. I mean, yeah, again, like Dr. Biani said, having trained at Great Ormond Street, bovine pericardium was very heavily used. And, but I think Professor Pang, by his, in his series, has proven that bovine pericardium is less irritative and causes, he's very, he's paranoid about the cord sac ratio in a lipoma, which has to be less than 0.3 and so on and so forth. Obviously, here in the Indian scenario, I try to extend the incision upwards. That is why I said the vertical midline incision, if it can be extend upwards and of course, it might look a little grotesque for a neonate, but if you go upwards and then find normal fascia and take a free facial graft and put it down, that can be a last resort. If we are not getting fascia which can be mobilized from the sides, we can extend incision upwards and bring fascia down. Like Dr. Biani said, tensor fasciae lata it's possible in a child, but then again, it's one more incision, bleeding, and so on and so forth. And so then, in cases where yes, sir. Yes.
Spray Tissot over it once you've done it.
Right, sir. Right.
Yeah. Sonal, what is your
comment? So the bovine pericardium that Dr. Saurav and Dr. Biani sir have mentioned, and Dr. Anda sir mentioned, that's essentially the same. So that's coming up in Indian market, very expensive, sticks and can be sutured and has minimum reaction. Premier Institute in Mumbai had come up in COVID times, because in COVID times the incidence of MMC had sporadically increased. So they came up with a study where mother's tissue was simultaneously prepared on the OT next door, and they use mother's tissue to close the MMC. The results are yet to be verified, but that is a novel idea as well. That's all.
Yes, it is. Very nice. Suhas, anything to add?
Yeah, I do use bovine pericardium nearly very frequently, actually. So, Esculap has a very good product called Lioplant, which is nearly cheap. It's around 15,000. So many times I've used it. It's called Lioplant, and I think rest as Dr. Naresh does, I would do many things similarly. But as Dr. Andar mentioned, I use a horizontal incision because, as he mentioned, you don't want to go to you don't want the incision to go down towards the cleft. And another thing which I find it interesting, and when you use a horizontal incision, is you don't, the facial defect is still separate from your main incision. The skin incision and the fascia is opened in a very intact way so that it can be closed in a very nearly watertight manner. The fascia, so there's no fascia defect if you open it horizontally. And I think rest is same as Naresh mentioned. I use IONM for all the cases. So I start off with exposing the normal cord and I map the cord, and then only I proceed with the rest of the dissection. So I know where to stay far from, and once I've identified the sphincter, the rest all is out for me. So IONM is a very crucial part of nearly. It's all surgeries actually. I don't do without IONM. Right. And the rest is same as Dr. Naresh would do. Thank you.
Fine, thank you. Any other question or comment from the audience?
One question I have for all the speakers and panelists. What is your experience, or what would you recommend, or what do you think about intrauterine repair of meningomyelocele? Have you got any experience? Is it going to take off? Not. We do that in some institutes here in this country, but I'd just like to hear from you guys.
Okay, so Naresh to begin with.
So Naresh, okay. Let's her speak.
Okay. Uday.
No, we had invited Samir Al Baba to Wade Children's, to hold a CME on intrauterine fetal surgery for minor MMCs, and we had a good discussion about it. I think in the Indian scenario, it may be a bit superfluous, but yes, it's a great idea because the MOM studies most of them have said that the benefits are much more than this thing. But in the Indian scenario, when we are dealing with two lives, the mother and the kid, it becomes very difficult to get a proper consent.
Yeah.
Yes, yes, it
And
is.
On the same note, I would like to add that I still go by Professor Sharad, who had published that if there is a high dorsal rachichiasis and if it is a patient from a village, I'll do my best to counsel them not to get operated. Because it is very easier to get a closure. It is very difficult to manage rest of life. So I think before we advise surgery, we have to be very careful and take everything into consideration, not just the surgical technique.
Yep.
Absolutely right. Very important thing. Any other question or comment? Dr. Kiawat is also around.
Can I talk on meningomyelocele?
Yeah, please.
Repair?
Yeah, Naresh.
I've been very conservative about that. We need to understand few things. One is that pregnancy is not a disease, it's a physiological thing. So the outcome has to be a normal mother and normal child. And the mom's trial, when it was being done in San Francisco, I was also attending that one of the centers there during that time. And they had to abandon that halfway because the mortality and mortality were much, much higher than expected, number one. Number two is that the main reason why the mom's trial was started was with the hope that the carry herniation would be less, the neurological deficit would be less, and the need of a VP shunt would be less, But again, when the result came in, when we have been seeing non-mom's trial MMC, the risk of hydrocephalus or like operating a carry herniation in a neonate with meningomyelocele in my career of 19 years of pediatric neurosurgery, I have seen only 3 children. So the risk is all overboarded, But then there are few centers now, they keep on publishing their data. And what they do is they pick up a very simple cases and they try to project that they are doing something great. Okay. So mom's trial, if it was very good, why would everybody in the world would not be doing that, So it's much hyper, but yes, it is used as a tool to impress people. And then there are certain specialized units that they do and they keep on publishing their data,
No, that is true. Very true, Naresh, what you said is, but, remember all the trials, there are certain protocols and, everything goes according to their setup and protocol. So that is why the results and the outcome or the immediate outcome is always much superior than, outside trial surgeries. That's why the post-mom trial, the results have not been very, very encouraging in any of the cases. And that is why probably it is not a very common surgery in North America and Europe. So
no, in fact, Europe, they are doing much better than the American continent, actually, France is much, much advanced. Brazil is doing big work, actually.
Brazil is doing very good work on
that. They are doing good work.
Yes.
But yes, the morbidity associated with the mother and delivering a preterm labor baby with other premature related complications are much, much higher than the benefit that we get.
Yeah. It's a very complex kind of setup and the understanding that we need to have with all parts of the people involved in this thing. Yeah. So Uday, you have something to say?
No, I'm just saying that I do see a lot of patients with the intrauterine MMCs, but many of the parents just decide on a MTP rather than
parents. Yeah, absolutely.
And I think just one of them went to Dubai. Samir Al Baba came all the way there and they got operated in that American hospital in Dubai. The kid is doing well. It's about 2.5 years now. But yes, it was a small one on the sacral area. It is the most ideal to do. You can do it even after the born.
Correct. Okay, Murali is there. Murali. Hey,
good evening.
Good evening. Any comment on the mom's trial and intrauterine surgery?
No, I have no experience with the mom's trial, to be frank. But the other discussion and presentations were excellent. So it's a good thing to. Nice to see all the youngsters presenting.
Yeah.
And seeing new faces and their experiences. Very nice. I include Dr. Andar also as young.
You don't.
Haven't seen you there for a long time.
He is mentor to everybody who is here,
Ever young.
Yeah, Naresh as well. Yeah.
So let's see if there is
Probably
any other.
the best person, I mean, to take up this sort of thing will be either in AIMS or in Amrita. If somebody wants to do a fetal surgery, to take it up. I don't know. Suhas, whether you have any
Suhas,
idea.
any situation? How the situation there in Amrita? You're mute.
Yeah. We have tried counseling since long. I mean, so we never could make a break in that. And so, and always I'm at least personally worried about the prematurity and its issues, which is a practical issue now all over NICUs. Having an IVH, having a meningitis, etc. I don't know. You treat myelomeningocele and you land up with meningitis, and what have you gained? I mean, so it's a very dicey decision making. At least I'm not sure how to go ahead with all this.
It's a complex thing.
Queer law called the PCPNDT law, not revealing the sex of the baby on an ultrasound. So when you're operating on a fetal on the uterus and you're doing a fetal surgery, I don't know if the MMC guys will come and stand there and do a PCPNDT survey saying that you cannot reveal the child's sex to the
gender. Yes,
it's a complicated thing.
it is. Indeed.
We will get a PCPNDT permission for it. That's the other.
Yeah.
Okay. Any other question, Kishore?
No, but I just one comment for all the speakers and panelists, and such a very high level of presentation for all the three speakers. That was really very enlightening and very, very encouraging to see such very good work being done. And I really thoroughly enjoyed it. Thank you very much. So for all of you, to all of you.
And is Dr. Patkar there? Hello. Yeah.
Still,
last word from you.
Suresh, if time permits, just one word.
Yeah, sure. Go ahead.
No, the problem is radiology. Now, the speaker on myelomeningocele was saying that everything is labeled as MMC. Okay, and this is something that we need to have a more coordination with radiologists to see that the terms, for instance, they don't label the limited dorsal myelosclerosis at all.
Yes, sir.
Hello?
I mean,
yeah, that is something that we have to look into, even the society as a whole, that everything with the cord coming out and I did one yesterday, which was labeled as myelomeningocele, but which was not. It was a terminal myelocystis.
Right.
Yeah.
Absolutely right. I agree with you.
That is something we have to look at.
Absolutely. Yeah. Uday, anything you would like to comment, or we?
No, nothing. I think we have got certain good radiologists here who label it correctly. We've been lucky.
Yeah, you're lucky.
Yes, we've been lucky.
Yes. Okay, then Dr. Patkar is there. I think he is disconnected. Oh, he is there. Yes. Before we close, just have a word with the speaker.
Regarding what? I learned so many
Generally
things.
generally about the
I would
webinar.
it was an excellent webinar. I learned many things, and very happy to see so many new youngsters and those who are pushing the frontiers further and further as compared to, there was nothing like pediatric neurosurgery when I was in neurosurgery. Everything was dealt by general neurosurgeons, but now we have got people who really are well trained and dealing with that. Thank you very much. I would just say I learned a lot.
You've already reached the disco, Sushil?
Pardon?
You've already reached the
Here I
disco.
am. You can see I'm in the disco.
Yeah. Have fun.
I'm all. You noticed that you're a brilliant chap.
Yes. Okay, so let me invite Dr. Jagtane, Dr. Nitin, to give a vote of thanks, and then we'll close.
Hi. मी ओळख नाही.
Hello.
Yes,
कुठे
Nitin.
Good evening, everyone.
कुठे भेटलं?
To start with, I would like to thank
काय
the
झालं
webinar
तुम्हाला?
committee, the MCNS EC committee,
अच्छा,
Dr.
अच्छा.
Sushil Patkar sir, Dr.
Really?
Milind Dunake sir,
20 years
the
ago.
entire MCNS
शिक्षणाचा
webinar
कार्यक्रम
committee, Dr. Suresh Sankla sir, Kishore Chaudhary sir, and Sarang Rote for arranging this webinar. Hello, can you hear me?
Yes, yes,
Yeah.
sir.
And then the two excellent presentations by all of our presenters today. Starting from Sonal Jain, very nice, technique. Saurav presenting his excellent work, and then with Naresh Biyani sir presenting excellent cases. And with that, I would like to thank our moderators also, Dr. Uday Kumaran sir, Dr. Uday Andar sir, and our main from the audience also. I like to thank all those who have participated. Dr. Murli sir, thank you very much. And last and the least, Dr. Kishore Chaudhary and Sankla sir for relentlessly coordinating and doing all these webinar series. And now I must say that looking at today's webinar, it was one of the best in the series. And I hope with the reciprocation from all and the participation from all these webinar series from MCNS, will take a big giant leap in the future. Thanks. Thank you, all of you.
Thank you. Thank you. Nitin. Thank you.
Suresh, just a
Yeah.
clarification. Suresh, do we
Yes.
have any CME credits for this?
No.
So we are planning to get it.
Okay.
Mostly that
Because
is one thing which is remaining.
The
we
main
will
problem
push
is that
for
it is just a very short duration webinar, 1.5 hours. So usually the medical council doesn't give any of.
Maybe we can plan it for a cumulative kind of thing. Maybe
Cumulative,
3, 4. We can club 2, 3
them together,
webinars,
together
and then we will work on that, sir.
Thanks,
Thank you,
Murali.
sir.
So
Thank
thank
you.
you, everybody, and Merry Christmas to everybody, and happy
Yeah, Merry-
holidays, and we'll meet
Thank
in
you.
next
Bye bye.
Thank you.
next year.
Thank you,
Thank you,
everyone. Thank you so
everyone.
much.
Good night.
Bye.
Yeah, good night.
ते होऊन गेलं. आता आमचं MCNS असतं त्याला जॉईन होत नाही असं होऊ नये म्हणून जॉईन होत असतं.